Going live now in a moment. As Noemi is off. So good afternoon, everybody. And it's Tuesday, the 20th of April, 1 o'clock. And here we are for our QI Talk Time. My name is Denise McCardle, and I'm a member of the National QI team and a new member of this QI Talk Time team. So I'm very excited to be here. And today we have a really fantastic webinar. We're delighted to have Winnie Ryan and Peter Gillen, and they are here to talk about communication in a virtual world. So we're going to learn about understanding the impact of using telecommunication for your consultations and to be aware of key communication skills for safe and effective teleconsultations. So what we're going to do now is, before we start, I'm going to just run through some housekeeping. So again, for everybody who's coming in, you're all very, very welcome. So sound. The reason we have this is that some people prefer, as well as watching us, is to use the sound of their telephone because they find the sound is a little bit better. So if you want to do that, we have the telephone number listed there, 015260058, and our event number today is 183-143-5752#. We have a chat box function, and this is because we want to keep these sessions as interactive as possible. So there is a little blue bubble, and you can see it down in the bottom right hand corner. So if you click on that, you'll have the opportunity to type in any questions, comments, queries that you have during the webinar, and we will at the end have time to address those. Also, I want you to know that we are recording this webinar and it will be available on our website. So if you want to go back and have a look after this, if you type QI Talk Time into Google, our website comes up, or straight into www.qualityimprovement.ie, and you will see an option down the right hand side for QI Talk Time. And engaging with us, which is Twitter. We're very active in Twitter. Our handle is @QITalkTime. So if you'd like to tweet, we'd love to see your tweets. If you feel like you'd like to take a little photo and send it in, please do. We'd love to see a photo, and anything that we can use to, I suppose, get quality improvement conversations starting around, Twitter is a really good vehicle for that. And also just to say that every time we're on, we're getting increasing numbers into QI Talk Time. So if this is your first webinar, you're very, very welcome. And also at the end, we really, really appreciate feedback because it's how we can improve our QI webinars. So there'll be a window will pop up just before you log out, and really, really would be very appreciative if you could just take that little extra few minutes and fill it out for us. And now our speakers today, as I said, Winnie Ryan and Professor Peter Gillen. So Winnie works in the Leadership Learning and Talent Management Division of the HSE and National HR. Winnie has worked at national level in the areas of quality improvement, patient safety standards, clinical guidelines, patient advocacy. She has a really long, I suppose, history and great experience, and her main areas of interest are leadership development, patient experience, again, and communication skills. And Professor Peter Gillen is an Associate Professor of Surgery at the Royal College of Surgeons in Ireland and the Clinical Advisor to the National Healthcare Communication Programme. Peter is currently involved in communication skills training and also a member of the International Association of Communication in Healthcare. So thank you, and we're just going to now introduce Winnie, who's going to start off. So please just give us 10 seconds. There's a little gap while Winnie shares her screen. So thank you very much.
Okay, can I just check, Denise, that you can see my slides? Perfect, okay. So good afternoon, everyone. And as Denise was saying, my name is Winnie Ryan. I work on the National Healthcare Communication Programme. I would like to thank Denise and all of the QI Talk team for firstly inviting us to speak with you today, but also all of the help that they've given us in getting ready for this presentation. I'm not very familiar with WebEx, so they've talked us through all of that. Just on the next slide here, if I can show it to you now. This is the outline of our QI talk time. So I'm going to talk to you a little bit about the National Healthcare Communication Programme. I'm then going to hand you over to Peter Gillen, and Peter is going to talk to you about communication skills for virtual consultations. And then just before the end, I'm going to summarise with some key learning points and maybe some takeaways from our talk today. And we hope you have some questions for us, as Denise said, that you would type into the chat box, and we hope to answer those for you at the end. So some of you are probably familiar with the National Healthcare Communication Programme, and maybe you already have that programme in your hospital. For those of you who are not, I just want to give you some of the background information. So the National Healthcare Communication Programme was set up in January of 2018 in response to the first National Patient Experience Survey in acute hospitals of May 2017. We've had an annual survey in the acute hospital since then, and the survey programme has also moved to maternity services and to end-of-life care this year, and will move into other areas of healthcare. So in the first survey, patients were asked a number of questions about their experience throughout the entire journey of care in the hospital or in maternity services. 3 of those questions were open-ended questions where patients were asked what was good about your experience, what could be improved, and anything else that you'd like to tell us about your experience. So patients had an awful lot to say to us, and the first survey yielded over 26,000 comments that patients made. So we read through all of those comments, and in reading those, it became obvious that patients have a lot to say about our communication, a lot that we're doing that's very good and that they like, and also areas for improvement. So with that in mind, Peter and I have been working since January of 2018 on this programme, and we've developed 4 core modules for training staff. Now, just to explain a little bit about our programme, we have 4 core modules, and they are delivered face-to-face or across Zoom at the moment. Our programme isn't an e-learning programme, and that's because all of the evidence around improving communication skills points to the fact that we can learn about the theory of communication in an e-learning programme, but if you want to improve your communication skills, you need to get feedback. You need to become aware of your own communication skills, what you do that's good, that you keep on doing or you do more of, and maybe the areas that you need to improve on. In order to identify those areas, you need feedback, and you can get that through maybe videoing yourself and getting someone to go through the video with you, or like doing role plays like we do in our workshops where we give you feedback. So from January of 2018 to March of 2020, Peter and I rolled out that programme in acute services, and we've moved more recently to maternity services. You'll see down there at the bottom of your screen, our programme is a collaboration with an international association called EACH. EACH is made up of staff and clinicians all over the world who have an interest in communication skills. Maybe they teach it, they're just interested in it, or they might teach it at undergraduate and postgraduate level. So they collaborate with us on the programme, and they give us feedback on all of our materials. So just going back to our communication and what patients told us about that. Everyone probably on this QI Talk Time today has been a patient at some stage, or you've accessed healthcare services, or maybe you are a relative or carer of a loved one who's accessed services. So we know that when we're accessing healthcare services, sometimes we're sick, and sometimes we might be feeling stressed, we might be anxious, we might be worried, we're usually vulnerable. So all of those conditions actually result at the impact on our ability to communicate. So as a patient, it impacts on my ability to give you information and also to take in information from you. And these conditions also have an impact on staff. So while staff might be very good at communicating with patients on a routine consultation, in a more stressful environment, like for example in the emergency department or in any kind of emergency situation, or a stressful situation where perhaps you're delivering bad news, disclosing an error, or responding to patients who are very anxious or very angry, if you're not very confident in your communication skills and haven't practiced them and very aware of them, it's possible that in those challenging situations that your communication skills are not as good as they should be. So we know from the feedback that patients have given us that when we use good communication skills to build rapport with patients, they appreciate that. They like it when we make a connection with them or when we demonstrate empathy to them and we show them that we are concerned about their worries and about their cares. We know that when we use good communication skills, active communication skills to show patients that we're listening to them, that they also appreciate that we're giving them time to tell their story, but also that we're taking on board their ideas, their concerns, and their expectations. And we're not just looking for the information that we want, but also the information that they want to give us and that we actually need to know so that we can make an accurate diagnosis or put together a treatment plan that the patient feels ownership of. We also know that a patient appreciates when we use good communication skills to give them information in a way that they can understand so that they can take that information away with them when they leave our hospital or our community care service, and they know how to look after themselves at home. They know the warning signs, they know what to do if something goes wrong. For example, they might know why we've changed their medication. If they understand that, they're more likely to adhere to it. So you can see here on the screen that good communication skills, and this is the aim of our program, we know the evidence tells us that good communication skills improve the patient experience, but they do so much more than that. They actually result in better healthcare outcomes for our patients because they leave hospital trusting us, feeling ownership of their care and treatment plan, and actually understanding how to look after themselves at home or what to do if something goes wrong. Good communication skills between colleagues, because we don't deliver healthcare in isolation anymore, we deliver healthcare in teams. And we know the evidence tells us that it's at the handover points of information that the most errors occur. So if we have good communication skills, not just with our patients, but also with our colleagues, that helps to improve patient safety. But good communication skills don't just improve the patient experience, they're also very important for staff. So if we have good communication skills ourselves, we are going to get more out of our jobs. We'll have better connections with our patients, we'll have better working relationships with our colleagues, we will feel we get very good feedback from our patients. That helps to boost our resilience and helps to protect us against burnout. When Peter and I meet staff, and we used to meet staff at our face-to-face workshops, we might have 30 staff in the room, and if we asked all those members of staff, you know, how many of you have had communication skills training at undergraduate or postgraduate level, at most 3 or 4 people will put their hands up. Now, why is this the case? It's because, Peter and I think, it's because mostly everybody thinks, well, I'm communicating since the day I was born, so I'm obviously able to communicate. That doesn't mean, however, that we're good at communicating. And a lot of the feedback from patients tells us that there are areas that we can improve on. How do I know what I'm good at? Well, I need feedback on this. And mostly we tend not to give feedback to each other in healthcare. So Peter and I organize our workshops around talking about the communication skills, then showing videos of staff using good communication skills, and then asking staff to role play those skills and giving feedback. Our program is based on the Calgary Cambridge Guide. This is an internationally recognized evidence-based framework. It contains 72 communication skills that we use across our consultations. Now, I'm not going to talk too much about this guide because we talk about it a lot in our program and I don't have much time today. The important point about this guide, though, is that we show staff that you use, of the 72 communication skills, you focus more on particular skills than others depending on where you are in the consultation. So for example, there are certain skills you'll use at the start of your consultation to build rapport with the patient. There are other skills that you'll focus on in gathering information so you can hear the patient's story. Then there are other skills that you'll use to give information to patients in a way that they can understand so they can recall it and use it at home. And in closing the session, there are particular skills we need to focus on to ensure that patients understand what the next steps are, what their role is, and to make sure if they have any questions that they get an opportunity to ask us those before they go. So when they go home, they know exactly what their diagnosis is, they know the next steps, and they have signed up to the treatment plan. The two purple vertical arrows on each side that you can see there are about the good communication skills that we use to keep building the relationship with patients all the way through the consultation. And also on the other side, you can see there are communication skills for providing structure. So we as healthcare professionals, you might have up to 200,000 consultations with patients in your professional lifetime. So it becomes very routine for us. But for patients, this might be the first time that they've had this type of consultation. And also, as I said earlier, they might be sick, they might be stressed, they might be worried. So it's very important that we use good communication skills to signpost our way through the consultation. This is what we're doing now. Now we're going to move on to this, and you summarize before you move on. So you're bringing the patient on this journey with you throughout the consultation. Now, as I said, Peter and I were running workshops up to March of 2020 last year. On the 12th of March last year, it's a day Peter and I will never forget, we ran our last face-to-face workshop in the Ashling Hotel in Dublin. I think it was Thursday. I went home on the train that evening to Ballybrophy, that's the train station near where I live in Neenah, County Tipperary. And the next day, my life changed and lots of people's lives changed because the schools closed and I was left with a 7-year-old to homeschool and also trying, like everybody else, to work from home. Now, up to that point, Peter and I had met a lot of nurses at our workshops who were saying to us, you know, we also do a lot of consultations on the phone. How can we apply the skills that are in this Calgary Cambridge Guide to telephone consultations? So we'd already started thinking about that. And then, of course, after the 12th of March, we had a lot more requests from staff all over the country in all of our hospitals and community care services saying, you know, we've never done consultations on the phone before. We're now having to do consultations using video. We don't know how to do that. And not only routine consultations, we might have to break bad news over the telephone or video. For example, saying, you know, your father's been moved to ICU, or I'm afraid your loved one has died. So around the end of March of last year, we started working on telephone consultations. And I guess for most people, this is really what it looked like. You know, are you there? Can you hear me? And hopefully we have none of this today, Denise, because I know you're working away on the background, making sure everything works smoothly. But for a lot of members of staff in hospitals and community care services, this is what their first consultations were like. So now we're going to show you a little video, and I'm going to pass you over to Ross, who's going to pull the video up on screen. And just while he's doing that, I'm just going to introduce you to the two people that you see here in the video. We have two people on screen. The first is Maura, and the other is Dr. Miriam O'Connor. Now, they're both actually facilitators of our program. So Maura works in quality and patient safety in South Tipperary General Hospital, and Dr. Miriam O'Connor is an oncologist in University Hospital Waterford. And last year, we were not able to make any of our videos, you know, face to face, but Maura and Miriam agreed to make these videos with us on Zoom. So Miriam is doing a virtual consultation with Mary O'Doherty, and Mary is a 52-year-old post-menopausal mother of 3 children. She was diagnosed last year with stage 3 breast cancer, and she's on endocrine therapy to manage this. And Miriam is now calling Maura using a video consultations to do this next review appointment. And this first example is to show you what a video consultation or a teleconsultation might look like if you don't have any awareness of good communication skills to use for virtual consultations. Now, Peter and I use videos, as I said, a lot in our workshops. Sometimes we make a good version, and the good version is useful because staff can see the skills and then can replicate them with success in their role play. But we also sometimes make a poor version, and that's what you're going to look at first here. And the poor version, it's a good icebreaker that we use in our workshops, but it's also sometimes staff will look at a poor version of a consultation and they'll say, well, you know, I mightn't be so good, but actually I'm not that bad. So it encourages staff, you know, to take part in the role plays. So I'm going to hand over to you, Ross, and please to play the video, and then Peter will debrief the video for us.
Hi, is that Mary O'Doherty? Yes, it is. Hi. Hi, it's Dr. O'Connor from the hospital here. Sorry, no, I just have to move the screen a bit here now, and I know it's distracting. Listen, thanks for taking the call today. We met this time last year, and we would be due, but with everything that's going on, the clinic is cancelled. So I'm doing this phone or this video consultation instead. Is that okay with you? Yeah. I suppose, to be honest, it would be nicer to meet each in person, but it's great now that you're taking the time to talk me through my clinic now. Listen, I might just crack on, okay? I just want to check a couple of things. Can you go over the name and the beginning of your address and your date of birth to me? Okay, yeah, it's Mary O'Doherty, and it's the 15th of April 1960. And I'm from Greater Care, County Tipperary. Okay, all right, okay. So listen, there can be some problems with the video consultation, so we'll just see how we're getting on with it. Is that all right? Yeah, that's fine, yeah, it's fine. It's great, yeah. I'm there now, I have a call to take. Will you just hold on for a sec? Okay. I think she's gone. What do I do now? Is there a number on that letter that they sent that I can ring back and see what happens now? Dr. O'Connor? Dr. O'Connor? Hello, Dr. O'Connor? No? Oh, very well. I just have to ring the number. Dr. O'Connor? Hello?
Okay, so Ross, can I share now?
You can go ahead, Peter, absolutely.
Lovely. Okay, so I think we all know the answer to this question, can we do better? Of course we can, and let's see how we might do that. So I'm going to talk to you really about, the title of the talk today is Communicating in a Virtual World. And really, we've got the arrival of telemedicine in the last year in particular. But it's not really an overnight success story. It's been around for quite a while, and as I've heard it described, it was in its adolescenthood for a couple of years, but it's certainly grown to maturity very, very quickly within the last year, even if it did take a pandemic to get it across the line. Now, so today I'm going to talk both about telephone and video consultations together, and where there are differences, and of course there are, I'll point them out as we go through, but there are many similarities also. So let's look at the advantages for the patient first. One of the biggest ones is that there's no travel time. We've all experienced driving, trying to find a parking space, all that hassle is taken away. We don't have to make a trip to the hospital or the clinic. And with that comes a lot of security in people's minds that they're not going to be exposed to the risk of infection, particularly, of course, recently with COVID, but even before that, about people's unease or anxiety about going into a hospital. For the clinicians, there's very good data emerging now that outcomes are equivalent, provided you select the correct patients. It's particularly useful and very, very popular for younger people with chronic disease reviews. For example, young diabetics, they find this excellent. It's also very good for things like prescription changes as well. But it does pose challenges, and that's really what we're going to concentrate on, I hope, today. So the problems are that reassurance may be easier by video than by telephone, because of course, as in the picture on your screen there, you're able to see the patient. And so non-verbal cues and performance will be picked up possibly by yourself, whereas that's much more difficult to do on the telephone. Another challenge is that older people may be wary of disclosing symptoms to a screen or a telephone, feeling that it's not the real thing. Similarly, interruptions may be off-putting. So if people are talking over one another, and we're all familiar with that on Zoom, for example. It's been documented now that elderly people can get quite discouraged by that, a little bit annoyed perhaps, and can switch off, as it were, mentally. There are challenges with privacy. So, for example, if you don't have the luxury of a pre-call from an admin person to set up the call, you might be ringing somebody in a supermarket, for example. So it's very, very useful to know where people are and to ask them if it's okay to continue with the call, and are they happy about the privacy that they have available to them. Sometimes people have chaperones with them, so you may have a relative or even a friend wanting to sit in on the call, and that can make people reluctant to speak. Even elderly people may not be very keen about discussing physical difficulties or mental problems with their children in the room, for example. The challenges for clinicians are also quite considerable at times, and it's best to remember that telemedicine may not be appropriate in some clinical settings. For example, if somebody has abdominal pain, for example, or breathlessness, then it's very difficult over the phone to decide if you're getting the whole picture. You might want to do a particular physical examination. And for example, the previous example of either being breathless or having abdominal pain might mandate a physical examination that you cannot do over the phone. Now, some examinations can be done. For example, you can ask somebody to show you their swollen knee, or to hold the camera by somebody else and ask them to walk across the room. So there's lots of things that you can do, and that's being expanded all the time. But there are limitations. Vulnerable patients are also a problem. And so if somebody is not feeling very confident or has some mental health issues, it may not be appropriate on occasions to have a telemedicine call. It's also more difficult for clinicians if you don't know the patient and it's a first consultation. And similarly, you may lack supporting healthcare records, which will make it even more challenges. I would like to say that interruptions are more common than face-to-face. It's a good rule of thumb to remember what I call the 2-second rule. So either on the telephone or on video, when the patient stops talking, try and discipline yourself to say in your head 1001, 1002, and then begin speaking. Because what we've got is, on the phone, you may be speaking over somebody, which, as I said, is quite irritating. On Zoom or whatever, Attend Anywhere, whatever platform you're using, there can be a signal drop or signal latency. Most of the time, we kind of know what that looks like and sounds like, and we can continue on without too much concern. But if the signal latency extends past half a second, which isn't terribly long, that can mean that there's a loss of signal for the patient and they may miss something vital. So be careful about that. If the signal loss becomes recurrent or goes altogether, then make sure before you begin that you have a backup plan, perhaps with video, to move then to a telephone. I'd like to mention this concept, which is becoming increasingly evident, called a wellness bias. Over the phone, not over video, but over the phone, where you can't see somebody and have no verbal clue, no visual clues, you may get the impression that the patient sounds okay or better than they actually are. And you get an idea that they are in fact better than they are clinically. And this wellness bias kicks in. You make your diagnosis a little bit presumptively, and you move on quite quickly, feeling that you've got all the information you need. And you may actually have missed something quite serious. So that wellness bias will lead to premature decision-making, which you may well regret in time. Let's look at the nitty-gritty for telemedicine. Before you start, you may be familiar with this acronym called hals, which is, are you yourself hungry, angry, late, or tired? If you're any of those, the S stands for stop. So grab a bite to eat, make sure you have everything you need, maybe take a comfort break for a couple of minutes, whatever it might be might be necessary. So prepare your information then, got all your notes together, and prepare your environment. So on a video setup, for example, how do I appear on the screen? Will the patient see myself centered? It's a good idea if you're doing consultations for a long period of time to turn off self-view so that you're not either attracted to looking at yourself or more likely that you'll develop visual fatigue by having more screens on view than is absolutely necessary. So try turning off your self-view. That will guarantee that you give your 100% attention to the patient. If you're going to use lighting to improve it, try and have it in front of you rather than behind you, which would put your face in shadow. And as I said, agree a backup plan with the patient that you'll move from video to telephone. I'd like to introduce you to this, what we call a CLEAR model. And this CLEAR model of communication originally comes from Medical Protection Society. And this acronym I find is particularly useful. So we're going to talk about connecting, listening, demonstrating empathy, asking, and reviewing. So connect would be, hello, my name is, and then listening. So listening in the beginning is okay when we're watching somebody. You can demonstrate that you're actively listening. There's ways to do that, and we'll talk about those shortly. But on the telephone, it's more difficult. And you're more inclined to get distracted as well. So we'll go through these in detail. So the first one is connect. I think many of us will have now heard of the term webside manner, which is, if you like, a bedside manner transferred to the internet. It's a phrase that's been around for a number of years, but is becoming commonplace now. Another new phrase is called netiquette, which is the internet equivalent of etiquette and face-to-face behavior. And these consist of a variety of themes. And the first and most important one is what we call the golden minute. So in the first minute of a consultation, you have the ability to make a connection with somebody. So make sure you use it. And that will lead to what we call the halo effect. Now that means that, akin to those pictures of saints from the Middle Ages always have a halo casting a light over them, meaning that they're very good and very humble people. So the halo effect is where your initial perception of somebody clouds other things about them for you. It can be positive or negative. In this case, if we make a good first impression during the golden minute, and how do we do that? Well, we introduce ourselves by name and role, and we break the ice a little bit. How are you finding lockdown, or what are you doing in lockdown that's keeping you going? Something like that. Nice, friendly, open, conversational tone. And on video, if you look and sound the part, then that halo effect will give you a bounce, and patients will engage and take a very favorable impression of you and bring that to the rest of the consultation. Be aware of your pace, particularly on the telephone and especially with older people. So slow down. Your tone of voice is essential for the telephone. You need to modulate your tone of voice, and that will convey interest and empathy, and a connection will be made. Avoid jargon. It's the same for face-to-face consultations, but avoid jargon, especially over the telephone. And this one is important. Don't be tempted to multitask. So if you're on the phone, there's a great temptation to have emails open or something else on the screen, and it will come across as being disconnected. The patient will get the sense that you're not fully listening, and if you like, you'll be found out. So please don't be tempted to multitask and give them your full attention. Listening on the phone has to be exaggerated. So on the phone, you need to use what I call phonetic encouragements regularly. Okay, oh, I see, right, yeah, in order for people to hear what to know that you're listening. Also, summaries, or micro summaries as we call them, is really important as well. So you might say, can I stop you there, Mary? So what I hear you're saying is that the headaches have become more frequent. that means that the patient will get that reassurance that you're actually listening. On a video call, do what you would do face to face. Lean towards the screen to show interest and nodding. Become a nodder. It's really, really an important skill. If you can nod as somebody speaking to you, they get the impression that somebody is actually listening. And allowing the patient to talk may tell you what you wish to know without even having to ask. Now, demonstrating empathy is much more difficult on the phone, as you've got no body language to aid you with visual clues that patients might be upset or might be worried. So you have to listen out for hesitation or a change in tone. That's difficult to pick up, but if you hear it, then you need to make quite formal empathic statements. They have to be more deliberate and more explicit on the telephone than at any other time. So you might pick up on something that they say that demonstrates that they've had a tough time. Well, then say it. From what I'm hearing, Mary, that must have been really tough. And say that at least once or twice during the phone call. And it's always a very good touch to use somebody's name at that point in time to emphasize the empathic statement. A is for ask and then tell and then ask again. So this is where we incorporate patients' ideas, concerns, and expectations. So here's a lady who's demonstrating on a video call that she has a pain in her neck. So it might be worth asking her after she's told us all about her neck pain is, what do you think might be going on? Well, I was in the garden last week and I was pruning hedges and it was above my head and I was using the clippers and I noticed the next day I was very stiff and it's got a lot worse. What are you most worried about? Well, I'm afraid that I've done some permanent damage to my neck. And what do you think is the best way forward? Well, I'm really hoping that you'll x-ray my neck and tell me that I'm okay. So you're asking, and now you've got an opportunity to tell them what they want to hear. And following that, you're going to tell them, have they any further questions? Ask them, what questions do you have for me now that we've been through that? And this is when we come to reviewing and check back. So there are 3 ways to do review and check back, and they're called the yes-no, the tell-back directive, and the tell-back collaborative. And there's some subtle differences between them. If you say to a patient, either on the phone or on video, I've given you a lot of information, is there anything you don't understand? The only possible answers there are yes and no, which may not do the patient a great service and feel that they've been pigeonholed into one or other answer. Then there's tell-back directive. It's important you do this exactly the way I explained. Could you tell me what I've told you? Sounds good, but it's not the best. The best is tell-back collaborative. I've given you a lot of information. It would be helpful to me to hear your understanding about your condition and its treatment. So to summarize, use the golden minute to develop your website manner. Listen and avoid interrupting. Remember that 2-second rule. And don't be afraid, either on the phone or video, to prompt the patient. Anything else? Can you tell me a little bit more about that? Empathy. Pick up on emotional cues. More difficult on the phone when you can't see somebody. But don't be afraid to say, this sounds really tough. Ask, what questions do you have about what I've said so far? And then review. I've given you a lot of information. It will be helpful to me to hear your understanding of your condition and treatment. Now, what we're going to look at next is Miriam and Maura having another go, if you like, this time utilising many of the skills that I've just elucidated. I'd like you to concentrate now on what you see of these skills in the following 4-minute video.
Hi, is that Mary or Dorothy? It is, yes. Hi, Dr. Connor. Hi, Mary. It's Dr. O'Connor. As you know, the consultant oncologist from University Hospital Waterford. Thanks very much for joining me on this video call. We met last face-to-face and outpatients in the clinic. I have a couple of things to check with you before going, if that's okay. Okay, yeah. But firstly, can you hear and see me okay?
Yeah, no, I can see and hear you perfectly. Yeah, that's fine.
So while it's perfect, I'm going to say that sometimes there are technical issues with the Zoom. Sometimes it freezes and it looks like I'm not listening, but it then picks up again. The reception drops, the picture freezes, and then it gets going again. If that happens, I'll repeat what I've said.
Okay.
And likewise for you. And then sometimes the signal drops altogether and we lose the connection. And if that happens, what I'll do is I'll revert to phoning you.
Okay. Yeah. Okay. Yeah.
So,
That's
so again, just to clarify, because we're not in clinic, can I just check your address?
yeah. It's Grangemore Care, County Tipperary.
That's great, because I've got your notes here. So just, if I look down this, because I'll have your notes here. Your date of birth?
15/4/1969.
Great. And then in case I say the signal drops altogether and I revert to the phone, can I check which is the best phone number to ring you on? And I'll write it down if that's okay.
Okay. Yeah. It's 081 555 2155.
Okay. So I'll just call that back to you. 081 555 2155.
That's it. Yeah. Yeah.
Okay, great. Well, hopefully we won't need to revert to the phone, but at least we have a backup. I'm nearly ready now. Is there anyone else there with you listening in? 2 sets of ears can be better than one.
My husband is here. He's here in the room with me. He's just over there.
Okay, that's great. Hi, Mr. O'Doherty. I do think 2 sets of ears are better than one. So great. So Mary, today would have been a routine consultation in the hospital, but with the restrictions in place, obviously that's not possible. And rather than cancelling and making no contact, we've reverted to doing phone calls and these visual communications.
Okay. Yeah. Yeah. I suppose if I was to be honest, I would have much rather meet you in person. But when I can't do that, this is definitely so much better. Just one thing, Dr. O'Connor, if you don't mind. When I knew I was going to be on this, when I got the letter from your secretary, I just made a few notes, bits of questions. If that's okay, I might kind of look at them every so often.
Yeah, that's a really good idea, because as you know, whether it's on Zoom or telephone or face to face, sometimes those notes will serve as prompts that can make sure that you get what you want to have addressed out of the consultation. Okay. So like you, I'd prefer to see you face to face. There are limitations with Zoom, both technical and the fact that I won't be able to examine you.
Yeah, no, I appreciate that, and thank you for taking the time.
So I've had a look at your notes, Mary. I have them here with me, and it's great to say that it's now 4 years since your surgery. I'm sorry, your last year in clinic. And while I might have a few questions for you, can I just start with, particularly when you've gone to the trouble of making the notes, what are the particular problems or queries that you'd like to ask me today?
I've been on the medication, as I said, and you're reading in the news that anyone that's on cancer drugs, that they're at high risk of getting coronavirus. And I suppose I'm just afraid.
Yeah. And you sound worried, Mary.
I'm just afraid because I've 3 children, and I've 1 at exams and 2 in primary school, and I don't know, like I need to stay well to look after these children. You know, I'm just worried, I suppose.
Absolutely, Mary, and it is a worrying time. So I will address that in a minute, but I want you to go back to your notes. What else have you on the notes?
Okay. So what I'd like to just do very briefly, because Winnie's going to take over again in a moment, is that in that video we saw exactly, can we do better? Yes, we can do better. And what's happened is that somebody has prepared, made a contingency plan if something goes wrong. They've done their preparation. They've begun well. That golden minute was very nicely illustrated there. And in particular, within 4 minutes of starting that consultation, we've had a number of really excellent communication skills demonstrated, not least of which was when Maura was asked, was there anything she wanted to say? She said, yes, I've made some notes, and when I knew this was going to happen, and I've got some questions I'd like to ask. And rather than, like a lot of doctors, just pressing on with your own agenda, Miriam decided straight away to say, look, I have lots to ask you, but since you've made notes, let's hear what you've got written down. And then there was a lovely demonstration of a typical mother, more worried about her family than herself, by saying, I'm on chemotherapy. You read all this stuff in the papers that maybe I could get coronavirus. And Miriam responded by saying, yes, you sound worried, which is a lovely demonstration of empathy. And then what she did was she said nothing. She paused, which is a really important communication skill. Because most doctors will pitch in with, well, the incidence of immunotherapy and so on is not that high. So, you need to be, that's not what was required there. All that was required was, you sound worried, pause. And then she said, the real reason that she was worried, I have 3 young children. And suddenly, by just giving her time to say that, now you know what her biggest concern is. And what she said after that was, it's normal. It is a worrying time. So she's validating that expression of worry, saying, I can see why you're worried, and it is normal to be worried. And then she moves on with the rest of the consultation. And as you watch her on screen, she's watching her directly and nodding and saying, it's normal to be worried. So even in that video is available, and we have the resource up for you. There's a lot more in that video, but I just wanted to highlight that within a few minutes of starting, her golden minute was excellent. Her fallback situation was explained, and already she's demonstrating empathy within just a couple of moments of beginning the call. Okay, Winnie.
Thanks very much. And I'd like to say thank you in particular to Ross at this point, who is allowing us to use the videos. It's not easy apparently to share videos on WebEx, but Ross has made it possible for us. Thank you. And I don't know if Maura and Miriam are listening in today, but really like to thank them for, in the middle of a pandemic last year, for taking the time to come up with the script and actually do the role plays for us. These videos, I think Stephanie has copied some links into the chat for you. So I have to say that Peter and RCSI gave us a huge amount of support last year in April and May by providing the technical support to make 2 online modules. So you can find these videos on our online modules. We have an online module for telephone consultations and one for video consultations, and they're hosted on the MS Surgery website. They are free and they're open to everybody to use, and we've had a lot of very good feedback on them. And also for clinicians, you can get 3 CPD points for going through those online modules. I'd also just like to take the opportunity to thank Peter Gillen, who is a retired surgeon, although from the amount of work he does for us, I'm sure his wife doesn't feel that he is retired. Peter is passionate about good communication skills and has provided invaluable support to our programme. And we are targeting our programme at all staff, because all the skills that I showed you there in the Calgary Cambridge Guide, they apply whether you're an admin member of staff, a clinical member of staff, and they apply to all scenarios, whether it's a routine consultation or you're delivering bad news or you're disclosing an error. And I think that's the beauty of the programme. And we didn't come up with that idea. That's actually because we were advised by the international organisation that we work with. We don't need to learn different models for different consultations. We don't need to learn different skills for different consultations. They're all the same skills. And what we do in our workshops is we show you how to apply those skills in different scenarios. So just before we finish, and I know we want to allow some questions, time for questions at the end, we always finish up all of our workshops with a summary of some key learning points, just so you can maybe take those away with you and think about them. So just to summarize what Peter has told you, I have a quote here on screen. I just found the quote and liked it, so I didn't know who Roger Maris was, but I found out for you. He was an American baseball player, and he held the record for the most home runs in a single season. He had 61 home runs, and he held that record from 1961 to 1998. And what he's saying here is, you can see, it's all about preparation. And that's what Peter's told you about. That's important for face-to-face consultations. It was always important to prepare yourself, to prepare your information, and prepare your environment. But we have another layer now with virtual consultations. So you might be doing, you know, as my husband was doing his virtual consultations with his patients at the beginning of lockdown in our bedroom door. So we had to put a sign on the door for the kids to say, don't interrupt. It's the same if you're using an office for your virtual consultation. So you might need to prepare that way. You might need to check your signals working. And like the preparation that we did to prepare for this webinar today, to ensure that the videos would work, that you could see the slides, etc. So when you're thinking about your virtual consultations, remember preparation, yourself, the information and your environment, and also to have that backup plan for your video. If something goes wrong, like Miriam did there on the screen, you say, we're going to move to phones, can I just check that I have your number? The next one here is a quote from Maya Angelou, and we have a lot of quotes from Maya Angelou in our workshops, and we like her. She's an American poet and philosopher. And this quote here relates to the C and the E from the CLEAR model that Peter spoke to you about. So what Maya is talking about here are the good communication skills that we use to make connections with people. And also the E of CLEAR, which is demonstrating empathy. So sometimes in healthcare, we have to deliver very bad news to people that we just can't fix. But in that moment, we can still use good communication skills to demonstrate empathy. So we mightn't be able to change the fact that the patient has cancer and there's no more that we can do, but they will always remember the good communication skills that we use to show them that we can see how worried they are, we can see how upset they are, and we're here to help. The next one here is Ernest Hemingway. He was an American novelist, and I like this one. There's another quote that I like, which says, never miss a good chance to shut up. So this is all about the L in that CLEAR model, which is about listening. I myself would have thought that I was quite a good listener until I started to observe myself and get feedback on my listening skills. We assume that we're quite good at listening, but when you watch yourself, you learn that actually we tend to keep interrupting people, usually to demonstrate that we understand, but often with patients, if we interrupt them, they stop telling us their story. So very important, as Peter said there, to ask the question, show that you're listening actively, nodding, leaning, etc., and let them tell their story. So often patients tell us in our experience survey, in the experience surveys, that they didn't get time to tell their story. And this one here is another listening one by Peter Drucker, who is a management consultant, and particularly important, as Peter said, on the telephone. The most important thing is hearing what the patient isn't saying. Face-to-face and on video, this is easier. You can watch the patient's non-verbals. Have they stopped keeping eye contact? Are they looking away, looking at the ground, looking defensive? Their eyes are glazing over, so you know they don't understand what you're saying. That's easier. On the telephone, very difficult. So more important to listen out for that hesitation or change in tone. What isn't the patient tell you, so that you can probe more. Then this is the last quote that I'm going to show you, and it's about the understanding. The biggest area for improvement in the patient experience service is really how we give information to patients. A lot of patients say that they're leaving the hospital or leaving the community care service not even knowing what their diagnosis was, and certainly not understanding how to care for themselves at home. If people don't know how to care for themselves at home or what the warning signs are, they are more likely to be readmitted to hospital. So as a healthcare professional or staff member, the information is it's not about know as a healthcare professional, it's actually how well you can communicate that information to patients so they understand it, they can recall it, and they can use it at home. So that's the end of my takeaways. I'll hand over to Denise at this stage for who's moderating, I think, the questions today. Sorry, Denise, I think you're on mute.
Can you hear me?
Yes, we can now.
Oh yes, apologies. Guys, thank you so much. That was a really informative, great talk. We do have a few questions in the chat box. We have one from Karen, and I suppose it's, well, she wanted to know how the program was being rolled out to hospitals, GPs, community and social care services.
Okay, so Peter, I can take that one if that's okay, and you can add in. So we started, as we said, in 2018, Denise, rolling out the program to acute services. We're using a train the trainer approach because it's only Peter and myself working on the program. So for two people, it would be very difficult to reach everybody out there in hospitals. So we have a lot of facilitators who've come forward from hospitals, and we're training those to roll out the program in their own sites. We've moved into maternity services. We haven't moved it formally into community services yet, but if individuals in community services are interested, they can email me, and we always invite them along to our workshops. We've engaged with the ICGP and other organisations also to adapt our programme to roll it out there. And again, please email me if you have any queries in particular about the programme.
Great. Okay. I'm just looking for, I suppose somebody just mentioned there in the chat box, and I suppose, Peter, you'd be aware of this was really important about data protection issue, where somebody, a relative, answered the phone and took the consultation began. And I suppose, that's a really, really important point to make. So if you have anything further on that, Peter, I suppose it's very straightforward in making sure that you're speaking to that right person.
Yes, it is. And I think as we demonstrated on the video, it's obviously a lot easier. On the telephone, I suspect that's where that happened. And it's a mobile phone, yeah. So you do need to confirm ID by more than one method. So name and then date of birth, or two identification tags first to get it. And then another thing that's nice is that I had a consultant say to me last week that he really liked the online module we produced. And one of the things we ask is, you ask the patient, are they comfortable where they are? It sounds a little odd, but actually a lot of elderly people have a landline in the hall on a coffee table and no chair. And when they take the call, they're standing. And, the consultation might take 15 or 20 minutes, and it's a long time for an elderly person to have to stand. And just simply by saying, would you like to sit down? And they go, get a chair, sit down. It's a wonderful connection, golden moment for people. And I think I'm not distracting from the point here. You do need identification, and then a nice little icebreaker, connection chat by saying, are you comfortable where you are? And then to continue with the phone call.
Okay. Look, we're nearly at the end of her time, and I'm just going to, before we wrap up, just ask Philip Crowley, who's a National Director of the National Quality Improvement Team. Philip, have you anything that you want to add? Is he there?
Only to say thank you very much to Winnie and Peter for really excellent. And I suppose the thing that always strikes me, I've done a few video consultations as part of training, and you do the video, and even when you finish the consultation, you think, oh, that's absolutely brilliant there. And then you sit down with your peer group and watch it, and it can be really embarrassing when you realize some of the things you do in consultations you don't realize that you're doing. So I think we can, some things may seem a bit simple for people, but in reality, we get them wrong so much more often than we realize. Yeah. So well done and I think, adapting for digital communication is really important, because as you've rightly pointed out, so many of the upsides will remain upsides regardless of any pandemic progress or not. So I'm sure we'll be continuing to use this technology into the future. So this kind of training is going to be important. So thank you so much for that. I did want to say something specifically as well. Siobhan Reynolds has been running these webinars for us for some time now, and previously she opted in to be part of the National QI team's effort to establish the contact management program, and she's now been recruited by that contact management program and promoted into a new role there. So she's going to be leaving it, which is very sad for us, but happy for Siobhan in taking on an exciting new role. So I really wanted to thank Siobhan for all the work she's done on QITalktime and with our team in general, and we look forward hopefully to welcoming her back. But really, thank you, Siobhan, and thank you, Denise, now for stepping into Siobhan's shoes so ably. But Siobhan, you've been great, and we appreciate everything that you've done for the team and specifically for QITalktime. Thank you.
Great, thanks, Philip. Just have a slide there that I just think it's part of the resources that you will find on our website for communicating with patients. And I suppose the important ones there are difficult conversations, the telephone consultations and video consultations. Now, guys, just as we wrap up, we would really like to know how we did today. So when you log out, there'll be a short feedback form that will pop up, and it will just, I suppose, help us improve in moving forward. And we really, really appreciate your feedback. Plus, as well, we really, really appreciate you tuning in. And also, just to give you some what we have coming up, on the 4th of May, we have a really interesting webinar, I suppose, learning from COVID-19 through stories, but actually the real name is of the webinar is going to be Nothing Like a Crisis to Get Things Done, Storytelling and Experience of Quality Improvement During COVID-19. So we're that's by Zinira Khurshid, who's also a member of our national QI team, and she is also with UCD. And again, then on the 18th of May, we have Dr. Amar Shah, who is a consultant forensic psychiatrist, and also he is the Chief Quality Officer of the East London NHS Foundation. So he is going to be giving us a talk on the whole system approach to QI. Again, guys, don't forget, tweet away if you want, send us on Twitter, and you can also catch our the recorded webinars on our website. So thank you so much, and thanks again, Winnie and Peter. Fantastic. Thank you.
Thanks, Philip.
Okay.
Take care.
Bye.
Bye now.